Welcome, everyone, to the session. Have a seat. Come up front. Join us in this conversation. This panel is how founders are improving access and equity by empowering community-based care. So join the conversation. Come on down. We'll start up with brief intros. Colby, I'll have you go first if you want to start things off.
All right. Hello, everyone. My name is Colby Takeda. I'm the co-founder and CEO of Pear. I'm a former senior living administrator and previously worked at population health programs like Blue Zones Project by ShareCare, and here I am with Pear now. At Pear, our mission is to help older adults and underserved communities address the social drivers of health, and the way we do that is by empowering community health workers with care navigation software. And happy to talk more about that as we go through today's talk.
Awesome.
Thanks.
Scott, on to you.
Hi, Scott Kaiser, geriatrician and co-founder of Determined Health. We are determined to transform care, elevating trust, connection, and humanity, all to improve health and support thriving communities. We have a community-based solution that really focuses on supporting human-to-human connection through a digital platform, and excited to share more today as well.
Lovely. All right, Veronica, on to you.
Hi, good afternoon. My name is Veronica Berry, and I am founder and CEO of TruDiary. And what our mission really is to create an ecosystem where all BIPOC women can have, great prenatal and postnatal care regardless of their socioeconomic status or community. We do that by connecting them with culturally relevant health literacy, education, and doula support. So I'm excited to be here. Thank you.
Lovely. Justin, last but not least.
Last but not least, my name is Justin Ayars. I'm the founder and CEO of equalityMD. I'm a recovering healthcare trial lawyer. I used to be on the dark side defending insurance companies. But what equalityMD is we are changing how the LGBTQ+ community perceives and receives care. We do that by having a inclusive virtual first platform where all providers on the platform have to go through LGBTQ cultural competency training so they can create a safe place where patients can be themselves. We're a B2B SaaS platform, and we also measure new patient data analytics because the American LGBTQ population, about 30 to 40 million people, is the most under-measured population in the country. And the actionable insights we'll be able to deliver to corporations, payers, and health systems will help higher patient engagement, improve patient outcomes, and foster more inclusive corporate cultures.
Lovely. And I'm the moderator for this session. My name is Shireen Abdullah. I'm the founder of Yumlish. We're a nutritional health platform. Think of it as the Peloton for nutrition that is culturally competent and inclusive. So we'll go ahead and kick things off with question number 1. So how do you, each of you, define community-based care? And what makes it an effective model for improving access and equity in healthcare? So very loaded question. Colby.
Yeah, I think we all witnessed during the pandemic, the importance of community-based providers and community levels approaches, right? I think the healthcare system quickly found out that they weren't necessarily the best people to approach communities of color, underserved communities, hard-to-reach communities around vaccinations. It was the churches, the community-based organizations, the YMCAs that were the best and most effective. And it's because of those relationships, the trust that they built. And so I think community-based care is all about how do you find the people, meet them where they're at, find culturally sensitive approaches, use language and culture and background experiences as ways to build trust and connect with these people, and then use that as a way to move them toward whatever action you're trying to take. So I really appreciate this conversation, and thank you all for being here.
Lovely. Scott.
So how to define a
community-based care, yeah. And what really makes the model effective?
I mean, well, of course, that's care that's really rooted in social determinants in where we live, work, play, pray, where we live and where we're with our people. And nowhere is this kind of more true and present than in geriatric care. When you think about the care of older people, we all know that you can live in one city and there can be a 30-year difference in life expectancy if you live on one side of town or the other. But then the question is, if you do get older, like, what does your old age look like? And, people don't appreciate the degree to which, women, people of color experience Alzheimer's at 2 to 3 times the rate. All sorts of issues in terms of who goes into nursing homes, who gets to age in place. So, and then when you look at what actually help people live well and age well, there's this whole network of community solutions and supports that are indispensable. Meals on Wheels programs, faith-based programs that get people exercising, senior centers. So, we believe that that works because A, they've been doing it for years and they have effective, evidence-based tools and solutions that can make all the difference in people's lives. But most importantly, there's trust and goodwill there, right? I mean, people just, we don't necessarily get a warm, fuzzy feeling when our health plan or health system calls necessarily. But, we have an affinity and a love for different organizations in our community that we may be connected with. So we really want to bolster and build those connections, and we know that's what works.
Veronica.
So I want to take it first from a perspective of my company is in Georgia. And when we talk about maternal health and we talk about community-based care, Georgia is one of the most dangerous states in the country to give childbirth. The maternal mortality rates are not good. And so the March of Dimes, every year they come out with a report, kind of a report card of all the states. And for the second year in a row, Georgia received an F. And so this is near and dear to me because I was a woman who experienced maternal health complications. And I attribute that to a lot of things, but one of the things I attribute it to is feeling like I wasn't being heard when I was at my doctor's visit, not knowing what questions to ask when I went to the doctor, and really not knowing what resources that I could partake of to have a successful pregnancy. So when I look at community-based care, I define it as a holistic care approach where all stakeholders are involved, and they always say it takes a village to raise a child. It really takes a village for women that are pregnant in Georgia. And I also feel like all stakeholders have got to be accountable. We have to hold stakeholders accountable when we're talking about holistic, community-based care.
Justin.
Patient-centric care, patient population care, for our community, the LGBTQ plus community, we're unique in that we are kind of the tip of the DEI spear. All the community populations you're talking about fall under the LGBTQ plus community as well. And so when treating our health disparity population as defined by the National Institutes of Health, we have to take into consideration the unique intersectionality of identities, the unique lived experiences of each individual, the unique social determinants of health that each individual has, and how to integrate them into a more comprehensive system that's user-friendly and that also integrates into the existing healthcare systems such that there aren't claims that are rejected by payers or corporations that don't understand how to institute DEI initiatives. And so a clear understanding starts with education, and it starts with working with partners that get it. And if they don't get it, or worse yet, they don't want to get it, you find partners that will, because only together can we actually effectuate change.
Justin, I'm going to keep it with you for a second for the next question, which is, what are some of the challenges and barriers, and we only have so much time, but what are some of the challenges and barriers that founders really face when trying to build and scale community-based solutions?
You want it numerically or alphabetically? I mean, when trying to build, lawyers are storytellers. So let me give you a quick story. I pitched to various VCs, as all founders do. I have been told several times as an LGBTQ founder, why don't you go to your people and find money? And I said, I am your people, because I was thinking I'm part of your ecosystem. And they said, no, your people. And they thought I was inferring that they were LGBTQ+. And then I said, but would you say this to an African-American woman? And the person walked away. That's just one quick story. The other barriers are people don't understand that the LGBTQ plus community is a health disparity population, not just because the NIH said that they suffer from unique healthcare concerns and suffer from a historical lack of access to care. What they left off is the most important part. They suffer from systemic discrimination from within the medical community itself. And that's often turning a blind eye during the AIDS crisis, where more Americans died on U.S. soil from the AIDS crisis in the 80s and 90s than died during the entire Vietnam War, because the Reagan administration turned a blind eye to the AIDS crisis, or because people are experiencing discrimination from the waiting room to the emergency room, in person and virtually, and every step in between. Acknowledging discrimination exists and figuring out a way to combat it in a way that's authentic and inclusive is a huge challenge, and one that we're hoping to overcome. And that's just in the practitioner side, in the field side, but it's also in venture capital, so that is a challenge for startups.
Gotcha. Scott, I'm actually going to throw the question to you next. Again, what are some of the challenges and barriers you see?
Well, you know, I've been as a leader in aging services for decades now. I've gotten a reputation actually as like the geriatrician in the room who's saying, hey, community-based organizations, they're doing great work over there. We need to get community-based organizations paid for what they do. Like, I can only do so much in the doctor's office. Like, we don't do that much in healthcare. It's 10% of the outcome. Community, community, community. So that's great, but the challenge is at the same time, it's kind of like then I'm vouching for my cousin, who's great, but he's got a lot of problems of his own, right? He might not even be the most reliable. They'll know what I'm talking about, right? So like, they're underfunded. They're struggling with so many constraints, so many regulatory and kind of reporting requirements. When you're dealing with senior services, there's a whole historic pathway by which they've been funded that's led to a certain systematic way. It's not necessarily person-centered. So it's really hard. And then you talk to investors and it's like, hey, we're gonna do this. We're not gonna just build around community. We're gonna build with community and help elevate. And it's like, well, will that really scale? Will that really scale?
Yeah.
So like, there are real challenges. But at the end of the day, it's the right thing to do.
Yeah.
So what we have to do as innovators and entrepreneurs, all of us, and this is what we're all doing, is like figure out how to do that and to make it scale and to make it work.
I do want to circle back to scale in just a second. I'm going to switch up this question real quick. Veronica, over to you. How do you measure the impact of your programs, and really what metrics do you use to evaluate it?
Well, that's a great question. So how we really measure impact is really change in behavior. And so what we know that there are a certain population of women who are high risk when they go into pregnancy. We also know that there are a certain segment of the population who get complications when they're pregnant. And so we look at it as if we can change behavior, there's going to be greater impact in the long run. So if we, bring about our doula services or health literacy education, and we can manage those patients with complications, but we can manage them to a full-term pregnancy. We can, avoid the baby going to NICU. We can encourage them and have them, have their postpartum visit and really, engage with their care team up into that 12 months. That's where we value impact, because we can actually see those real numbers.
Colby, same question to you. What are some of those measures that are important to you?
Yeah, measurement is key. I mean, I think a lot of the organizations, if you're not measuring things, if you're not evaluating scale and the financial value of the impact value of a lot of these programs, you won't be able to justify the expenses paid, right? So I think it's really important. I'm going to introduce a concept that I'm curious, who knows what a community health worker is? Wow, okay, interesting. So I recently came from a conference and asked that, there was a question brought up in the room, and a doctor stood up and said, I have no idea what you're talking about because I've never heard of a concept of a community health worker before. And so, the interesting thing is they've been around for decades and decades and decades and been doing this work in the community. And we think about community-based care, it's the kind that it's personalized, it's person-centered, it's customized based on the background, the interests, and the needs and opportunities of that person. And community health workers have been key to this. Measuring that, of course, has been a little different, right? Community health workers aren't necessarily in the EHRs documenting and knowing how to bill. They don't understand Z codes and ICD-10 codes and what matters to the health plans, which are obviously the ones paying for this. And so that's it's important to us to understand what they're doing in the community, how they can measure it better, how we can get that data back to the people that are paying their bills, and that's how we can really compensate them fairly and value their work in the community. And so it's about how do we get the data that we need from the community members through people like community health workers, these lay workers that oftentimes are building relationships, are in the community, asking the key questions, getting the information about the members that can be personalized and specific to their needs and interests, and getting that back to the people that are paying the bills. And so I think things like social determinants of health data, tying what they do in the community around food back to things like ED visits and screenings and annual wellness visits. How do we tie what they do in the community to HEDIS and STARS and those other quality metrics? I think that's a key for us to, one, support community-based care through organizations and groups that are in the community using community health workers and promotores, and how do we get that data back to people that are paying their bills? Thanks.
That's lovely. And, for us in particular, as we're looking at nutritional health and building that nutritional literacy for individuals, it's so important to look at measures like weight loss. But that's only part of the story, right? That's only one part of the story, an important one, but yet a very, just one part of it. And so then it becomes about thinking through sustainability. How does weight loss matter to an employer? How can we think about sustainability and scalability, which is one of the things, Scott, you brought up. And switching over to you for my next question, how do you address concerns around sustainability? Because it's great to have a community-based program, but you got to scale it. Yeah. So how do you think about sustainability and then funding such initiatives?
Well, I think, like I said, we're all about connection and trust. So that's obviously connection between people to effectively reduce loneliness, social isolation, and get a continuous view and relationship in terms of people's everyday lived experience. But we have to do the same thing with our community partners. It's years of work of building trust with our community partners, and that's why we're so proud of our partnership with Meals on Wheels America and works we've done with YMCA and other incredible community organizations. So we have to build the trust, and then our job as the innovators is to bring the technology to help equip them with the tools they need to help close the loop, right? There's just we all know that there's fragmentation between community care, health systems, and health plans, and so our job is to create technology that closes those gaps, eases workflows for our community partners, equips them with the data and metrics that they need to be successful, to procure the funding they need to succeed, and to share in the value that they're generating.
Justin, over to you.
Scalability, it starts at ground zero. And in this market right now, direct-to-consumer is kind of like beating on the death drum because it doesn't seem to be scalable. But direct-to-consumer is a milestone, not a destination. We pivoted from a D2C model to a B2B model, but in our community, the product that we are creating is so intentionally built around each individual's unique patient identities that if I go to the Los Angeles Community Center, for example, which is the biggest community center in the world, that does a lot of STI treatment and some basic sexual health education, I'm not going to turn away 100, 1,000 people, individuals, if they say, we need your plan, your platform, because I don't have an employer that would utilize this as part of their employee resource group, as part of their health benefit package, or even as a fringe benefit. So to start, you need to have that initial traction, measure, get the feedback, iterate, grow, and leverage your partnerships. And we're blessed that I jokingly say I've been building this company my entire life without even meaning to. After the Great Recession told me to go find something else to do after defending insurance companies, the pink slip was the best thing I ever got, because then I got to go out into the world and start building relationships by showing up, being my authentic self, and giving first. And now, with the pandemic, I look back and I realize we had a go-to-market plan I'd been building my entire life without knowing it for healthcare. After I said, God damn it, I have to go back to healthcare now. Because with that network, I felt I had an obligation because I had an opportunity to actually activate that network in a way that I never thought possible, to have an impact on a problem that I've experienced myself and that countless people have asked me, where can I find a doctor I feel safe with? And scalability is all about relationship building. Trust I've heard a lot about, and people talk about broadband, for example, access to care. That is not a silver bullet, because if the person in the rural community finally gets broadband to their house, there's not a big celebration, because does that person in that rural community, once they have broadband, trust the provider on the other end of that broadband network? And the answer is probably no. So that trust takes time and partnerships.
Yeah. Speaking of partnerships, Veronica, for you, what partnerships have been most effective for you in your model?
So one of the things that I wanted to add is we talk a lot about trust. And when you're talking about scaling, you really need to involve the community or the population that you're building for. You have to let them have a seat at the table. Yeah. You'll waste a lot of time if you don't include them, because you'll just be building. So a lot of it for even maternal patients, you have to be talking to them from the onset. So the partnerships that have been most successful for us, obviously we've partnered with Emory Health in Atlanta. They're very concerned about maternal health outcomes, obviously, because where the state of Georgia is. But another partnership that we welcome that has been very successful for us is a partnership that we have with Walmart. They have a policy lab, and we haven't talked about policy yet and how that is a bigger part of the overall outcomes, because you have to have legislation in place for a lot of these services to make them come about and to make them be reimbursable. So one of the things that we do with Walmart, we're kind of the liaison between the community, because we have the trust, of the maternal health community, that population in Georgia. And so we've partnered with Walmart to actually go to these forums in Washington and really tell a story of a mom in Georgia, in rural Georgia, and explain to these policymakers why it is important for you to pass legislation for that.
There's certainly a lot of advocacy to be done there and just bring awareness. Colby, same question for you. What partnerships have been effective in scaling your model?
Sure. So I think what's interesting is, especially during the pandemic, when equity and access were issues, I think organizations, health plans, health providers look to community-based partners and organizations as key partners. And I think what they've really quickly found out is that they operate very differently from large health systems, from large health plans. And just understanding how their business model works, how they make money, how they pay their staff, what staffing they even have, if they even have staff at all. I think it was very eye-opening for them to understand how these organizations work. And I think that's a key factor and a key partnership to make, is how do we start bringing people together that are from different industries and sectors of the organizations and that need to help address equity and access to healthcare. Once we bring them together, they can start talking, being on the same page about things like how do we work together and finance each other, how do we support each other with data, how do we support each other with technology. I think those are the key partnerships we need to form. Academics have a key role in this as well. How can they help us with evaluation? And then how do we get policymakers to the table, because they, at the end of the day, are going to be helpful in helping us make these models work. If it doesn't pencil out, it won't work and won't be able to pay the organizations that we need to really scale this community-based care.
And this one is a question for anyone here. When you're looking at talking to your customers, one, can you identify who your customer is? And then more specifically, what is the value proposition that you position the work that you do to your customer to get them excited about reaching your end user?
3 words for companies: double bottom line. You can have impact and make money if you do it right, and that is why corporations are, I've been cold called by a blues partner, by another major provider out there, payer out there, and by corporations that have been given LGBTQ mandates from on high, and they have no idea what to do with that. They know it's a problem, but so they're calling me asking for a solution. And that's an incredible way to begin a conversation about health equity and how we can help achieve that by having an inclusive healthcare platform within an employer healthcare system so that it's the best way to attract a diverse talent pool, because 20% of millennials and 31% of Gen Z self-identify as LGBTQ+, and also retain talent while remaining competitive and, importantly, culturally relevant in our evolving society.
Anyone else, Scott, you want to take that?
Yeah, sure. And but I wanted to go back to the partnerships one, because I know I talked about partnerships, but a little bit of my gratitude practice here. Also, our ecosystem innovation partners like StartUp Health and others, you know, it's amazing. We're so excited. We're in this CF Medicaid innovation cohort, and just the entrepreneurial ecosystem. Like, I'm excited to connect with everybody on this panel and do the good work. In terms of the value prop and who our customers are, you know, it's health systems, health plans, and CBOs, ideally getting all three working in unison. And we've come with all of the stuff of, you know, you'll improve this outcome, you'll reduce this cost, you'll address this workforce challenge, you'll better address social determinants of health. But the amazing thing is, we've all said it, so I'm broken record here, the trust piece. The fact that we increase that, that's the funny thing, is we get in the door with all these other value props, but then we do it and our customers see, oh my gosh, our satisfaction is going through the roof. Like, people feel an affinity, they feel part of a community again, and that is invaluable. So for anybody who knows how to measure that, measure trust, I'd love to talk to me after. That, I mean, I've been looking the literature, like, how do you actually measure that? Because anyway. So.
Appreciate that. We'll go through 30 seconds for everyone. I would love to get everyone's take on this. Specifically, speaking of just leaving on a very heavy question here, how can policymakers and other stakeholders support the growth and expansion of community-based care initiatives? And what changes would you like to see to further advance your work? I'll actually go first on this. For us specifically, as we talk about nutrition, I almost feel that when we talk about food as medicine, we're almost limiting ourselves, and really the approach when it comes to food as medicine, when we limit it to just meals and foods, it's also about empowering the individual. And from my perspective, I would love to see the conversation shift more to building that nutrition literacy, that nutrition competence. I would love to see some of that change come through. Colby, how about you?
Sure. So again, community health workers are key to a lot of this that we're doing. Pear Suite is building software specifically for community health workers. There's 15 states right now that the Medicaid plans actually reimburse for this. It's very interesting to see and how they're actually rolling this out. In California, you can only make about $26 per half an hour for 1 unit of care through a community health worker. And you think about how does that scale economically? It doesn't. It's really hard. What's exciting is that they're actually allowing community-based organizations without an NPI license, without provider status, without a clinician in the organization to actually bill for this stuff. So that's exciting. It's a move in the right direction. But of course, we have to get our billing rates up. If we want to see this scale, we want to see more organizations, MCOs actually be part of the conversation and actually get the right value back to our community-based partners and community health workers that we need to make this scale.
Lovely. Scott?
Yeah, I mean, I guess I want to see more investment in holistic community solutions for me, for my wheelhouse of aging, to think holistically across the life course in terms of how we can have equitable access to really long, healthy lives. I'll even go just sort of micro for a second. You look at something like dementia, right? There's 6 million people with Alzheimer's, 7 million people with Alzheimer's. That's a big number, right? But it's not an infinite number. And there are policies and funding opportunities today that we could put in place that could ensure that everybody diagnosed with Alzheimer's and their care partner could have access to supports and services that could make a huge difference in terms of their health and quality of life. And again, that could be done today. It's not an infinite number, it's a big number, but community by community, we could change all those lives today.
Veronica, Justin, I'm going to give you 30 seconds.
Okay, so what I'd like to see is doula support be reimbursed. So in the state of Georgia, doulas are not reimbursed. They don't get paid for the work unless it's out of pocket for mom-to-be. And so there is a pilot program going on right now. And what we found is that women who have doulas are 3 to 4 times more likely to have a better health outcome, maternal health outcome, when you insert that doula in. So that's what I'd like to see be implemented.
30 seconds, make it happen.
I can do it. 2 words: curiosity. If you're curious, that means you're going to look for solutions that you didn't even know were there and find problems that you didn't know existed. Second, compassion. Frankly, give a shit. Because if you do, you're going to be able to create a solution to problems that are going to affect millions of people. And that's what I would encourage everyone to do. Curious and compassion.
Perfect. Give a shit. I love that note. Perfect note to end on. Thank you, everyone here, my panel, for joining me here. Round of applause for them. Thank you to you for sticking around, listening to this. Come find us if you have any questions. And thank you to StartUp Health once again. Have a good one.